Thanks for having me. And for the everyone, this is my aim here is to just have a very informal discussion and make this an opportunity where you can ask any question you have, because I think there's a lot that goes into succeeding in academics, whatever that means, getting where you want to go in academics, that doesn't get discussed. And it's a really important part of the mentorship uh, duty, really, I think. So I want this to be an opportunity to just talk about those things. So I'm not saying the way I did it is the way to do it. It's one way, and I'm still doing it, but this is my path and some of the things I learned along the way that no one really sat down and told me. So I'm going to sit down and tell you, and hopefully it'll help at least one of you at one point in your careers. Here are the disclosures, and then well, I'll just talk about how I got interested in global health, what drove me to pick this as my main research focus, the lessons I learned and the decisions I made, and things that just kind of happened that I didn't really intentionally do that helped me or hurt me. Some advice, and then I'll leave some time for questions so that we can have a discussion. So this all started for me back in 1998. It is hard to even think of the world as it was now because there was no cell phones, no cell phones, and the internet was like barely happening. There was, Hotmail was what you used, and it was a dial-up situation, and the world was not the way it is now, where you can Google anything and see anything. So, as an American, I met somebody who'd done a program called the Peace Corps. The United States government has a program where they send young, or sometimes not young, my aunt did it when she was in her 60s, Americans to other countries. And the mission is really cultural exchange and understanding the world, because it was very hard to do back then when we were all so much more isolated, and still really important now. But also help if we could in any area of development. So I volunteered to do this when I was 23. I had finished my undergraduate education, and I said, I'll go wherever you send me. And they sent me to Senegal. So I went to Senegal, and the only thing I knew about Senegal is I went to our local bookstore, and there was a Lonely Planet travel guide on West Africa, all of West Africa. And they had like 3 pages on Senegal with 2 pictures. And that's all I knew about the country before going, because we had so little information at the time. So here it is. Here's the map of Senegal. Many of you may be familiar with it. Dakar is a very especially now, it's extremely cosmopolitan, very industrialized, very beautiful city. I lived over here in the east of Senegal, which is closer, kind of culturally in a lot of ways, to Mali than Dakar. And then my village looked like this. So I was a village of 250 people or so, and we all lived in mud huts. There was not one fixed, concrete structure for miles. There was no running water, no electricity, no school. So kids had to walk very far if their parents wanted them to go to school, and most didn't because it was too far, and kids had responsibilities that families couldn't afford to have them slack off on. So I landed in a place where people actually didn't really know very much about America, and I didn't know very much about them. So it was a really deep cultural exchange, and it took a long time to build that kind of trust. But I did. That's my hut. I had my own hut. And this is the kids in my family who thought I was like the most entertaining thing on the planet. I was their TV. But they were great. They taught me Juillard, so I learned a local language, and I still speak it. And it's a great language if you work in West Africa, because Fulani people are almost in every country along the Sahel. From Senegal to Ethiopia, you can find them. So everywhere I go, I find Fulani people, and it's a great connection to have. Um, and I made another family there because I was isolated. That worked both ways. Once I got there, I barely ever talked to my family. To get on a phone, I had to walk about 4 miles to find one person who sometimes had a phone that sometimes worked, and I paid by the minute, to have spotty connection. There was no internet. I had to take public transportation to get somewhere where there was internet. So I really learned how, I'm so grateful I had this experience at that time because I was forced against my comfort to learn the local culture, language, and make deep friendships in a culture that's extremely different from my own. And by the time I left, I felt extremely comfortable. I spent 3 years there. I felt very comfortable living in an African village and speaking Pular. I was dreaming in Pular. It was, I really got immersed. So this was extremely important for me as a person and my personal development, but it really opened my eyes to a very different way of solving the problem of how to live in this world. And the Pular solution is very different than the Los Angeles solution. But both places have worlds within worlds in them. And I was exposed to people who had extreme poverty and the consequences of that at a very close range. So that personalized health for me in a way that it hadn't been because I grew up in a very privileged and very lonely culture. So this really, I had friends who died while I was there. I watched children die. Every woman I know had lost a child there, except for one. My friend Suna actually didn't lose any of her 8 children, which is rare. And so health became a very real thing for me. And this drove me to go to medical school. The other thing I should mention, when I was there, I was in a car crash. Mark has heard this story. I was on a public transportation going to a regional meeting. They had them like once a year for us. UNICEF was having a training. So I was going to Tambakunda, the nearest big village, and a vehicle just like this one, the driver fell asleep. I think he'd been driving many, many long hours, as they often do, and went off the road and hit a tree. And we had a mass casualty. So it's 2 people. I heard that 2 people died. I don't know for sure because statistics were not routinely collected on road traffic crashes at the time in Senegal. I was minorly injured, but I did get knocked out and broke my nose and twisted my knee. But I was able to walk out of the vehicle, but many people were not. There were many people with fractures. At least one person lost their leg. And it really struck me how the only people available to help us on that road were another car that happened to drive by a few minutes later, which it was early in the morning on a rural road. It could have been an hour before somebody showed up. And those kind people pulled over. They put us, 5 at a time in the back seat of their sedan and drove us to the nearest health post. And at the local health post, there was one nurse and a nurse's assistant who triaged a mass casualty that would have been a major event in an urban level 1 trauma center in the United States. So I wish I could say that this was like my epiphany about doing global surgery, but at the time I was doing public health in a village in West Africa, and I was charged with the same public health mandate that had been happening for many years, which is, infectious disease spread, water and sanitation, all very critical fundamental things, but nothing surgical, nothing trauma, nothing injury. Injury was an accident to me at the time. It meant like something you had bad luck. It's not preventable. That's the way it goes. It's too expensive to develop surgical systems. This is how life is over here. And it wasn't until later, after I went to medical school at UCLA, I was wrong a lot. I thought I was going to go into family practice because I wanted to do public health. I thought I was going to work in community health and development. Again, wrong. And I thought I was going to go back and live in Senegal afterwards. Wrong again. I had all these ideas of what I was going to do, and none of them were right. During my rotations, I liked surgery in medical school, and I was like in an existential crisis because I thought, how am I going to marry surgery with my love of public health? I loved grassroots public health. This is going to be, I can't do both. So I struggled and struggled. Surgery and public health just seem like very different worlds. This is me operating as an intern with Dr. Atkinson, who's a fairly well-known pediatric surgery, kind of a legend in his field. He is retired, but it was at UCLA during my training. And that seemed like a far cry from, the only surgery I'd done in Senegal was butchering the chicken to make dinner when we had one, which chickens are delicious. So I was always involved in that part of it, but very different world. So I had a hard time reconciling that. And I met some key people while I was interviewing for residency that forced me to look at how to do public health and surgery and whether it was possible. At the time, the traditional model was it was international health and it was mission based, and it often relied on short-term interventions and you treated individuals. So surgeons essentially would go from the global north or west to the global south or east and provide charity work. And I had a lot of issues with that because it didn't really resonate with the Peace Corps volunteer in me about creating sustainable, meaningful, mutually empowering relationships and ultimately positive change in both of our worlds. So this has led me to think a lot about this. And Mark is my trainee. Mark is of another generation. Now the word global surgery exists. People can come to me and say, I want to go into global surgery. That didn't exist at the time. There's people were like, why would a surgeon be interested in public health? And why is surgery even something we should consider from a public health perspective? And here are the things I think are the root of the problem. The perceptions of surgery are that they're not preventative, they're curative. I think we know that there's definitely several examples of surgery being preventative, C-section being one, circumcision being another in public health now. Its focuses on the individuals. It's not population health. It's high tech. It requires a lot of skill and it's not cost effective. It's too expensive to develop surgical systems. So those should be reserved for rich countries and rich people. The perceptions of public health is that, oh, it's a preventative approach. We focus on population health. It requires low-tech solutions. We need cost-effective solutions, and we prioritize equity. And that's really where it bothered me, the equity piece, because why should surgery only be for rich people? Why should surgery only be for rich people? That bothered me. I watched people die of surgical disease in Senegal that could have been easily treated in the United States and not expensively. So this didn't resonate as true to me, these two different perspectives. Now, as a general surgery resident at UCLA, we have to do 2 years of research in our 7-year post-medical school residency. So we do 7 years of residency, 5 years of clinical, 2 years of research. And so for my 2 years of research, I went and got a master's in public health. I went to Johns Hopkins because they had and still do have a great international health program. And then I spent 3 months at the WHO in Geneva with a surgeon named Charlie Mock, who was the one I met during my interview schedule when I was a medical student, who kind of inspired me because he's a surgeon, trauma surgeon, who also has a PhD in epidemiology. And so he figured out he had the same issues with it that I did, and he had started doing something about it. So I wanted to work with him, and I'll talk more about him later. And then I went and spent a year in Cameroon. And so this is kind of where my global surgery, now that it's called that, journey began. Okay, so this is where lesson number 1 comes up for me. Mentorship is a team sport. At the time, at UCLA, and as in most institutions in the United States, there wasn't anyone doing what I wanted to do in terms of research. There was no mentor for me, one mentor, but there were a lot of really skilled people in a lot of different ways. So I've quickly realized I had to create a team. And for some mentees, I've noticed this comes naturally. It did for me, but for others, it doesn't. And so one thing I would impart to you is if you don't have a mentorship team right now, I would think about who your mentors are, what their skills are, what their strengths are, and if there are any gaps. Typically, I think everybody, especially if they're a clinician, they need a clinical mentor, a professional mentor, and a research mentor. And I would say if you're not a clinician, you still need those 2 other things. Sometimes your research mentor is not your professional mentor. I have a professional mentor who has helped me more than probably anyone recently. And his research is in something totally different than mine, but he's helped me navigate certain things institutionally and in terms of funding that have been critical to my career. So I did this as a resident. I had our program director at the time, who's now our chair of surgery, Joe Hines, help me by saying, yeah, well, you can do that. You can go do this crazy idea. It doesn't make sense to me, but I trust you. And we'll keep your health insurance and make sure you don't get cut off administratively from UCLA while you leave. Then I had our trauma director who helped me navigate how to set up myself for going into trauma surgery, which I ended up wanting to do. Here's Charlie Mock. He was probably the closest thing I had to a holistic mentor, but he was not at UCLA. He was at University of Washington. And when I met him, I stalked him. I kept in contact with him. I wrote him emails for 2 years before I went into the lab, research years. And I asked him, at that point, he had gone to Geneva, took a sabbatical from clinical work and gone to Geneva to work at WHO. And I said, I'm going to come meet you there. What can I do to help? I paid my way. I figured out how to get there. I made it happen. And then at Hopkins, I was lucky enough to meet Adnan Haidar, who's a neurologist. So he was interested in injury from a disability perspective. And he is now, I think he's at George Washington University and runs their whole global health division. And he's a fantastic researcher. So he mentored me in my MPH. And then I met Cliff Coe at UCLA, and he helped me because he was a pioneer in surgical outcomes research, which at the time when he was a resident didn't exist. And he was one of the people who started to create and establish a new field. And he was one of the voices that said, you have a new idea. Don't be discouraged if people don't understand it. Just do it. And that was so critical to have someone who knew how to be a trailblazer as a mentor. And then I had Marie Diener West, who's like the kindest person in the world and a phenomenal biostatistician, now the dean of the MPH program at Johns Hopkins. And she was my biostats teacher, and she helped me figure out how to do my first analyses looking at injury questions. So it's a team sport. I also had mentors later along the way. This is Dr. Shishom, who I met, and Dr. Manono. I'll talk about that later when I was in Cameroon during that second year. Okay, then my second year, I get to Cameroon. Here's the hospital. And let me just show you some pictures. Some of these may not be surprising to any of you. There's all kinds of like feats that defy physics that we see on the roads in places like Cameroon and Senegal. This is the hospital where I work, the Central Hospital Yaoundé. And what was really interesting there is I went to Cameroon as this oddball surgeon who liked public health, thinking I was going to have to do a lot of explaining of what I was trying to do there. And when I got there, every person was like, yeah, road traffic crashes are a huge problem. Injuries are a huge problem. Like, what is anyone doing about it? We have all this, money for other problems from international organizations, and we're making some headway on those. No one seems to care. We're dying on the roads. Everyone I met had someone in their family who'd been impacted by injury. This is a slide. This is a picture from Dr. Shishom. He took this where there's a red and a green light on at the same time. That's just one of the problems on the roads in Senegal. In Cameroon. This is Cameroon. So number 2, partners are the key. I met the key people that I ended up partnering with for the rest of my career to date. I met when I was a research resident in Cameroon. So this year, where those of you, you have this GloCal opportunity, and those of you who are from the US and are living in other countries, this opportunity does not come very often. Dig deep. Don't worry. I mean, yes, get the research done and check your boxes, but eat dinner with your colleagues, go to their baptisms and their weddings, make the best effort you can to understand what's going on around you, because it's not often, if you're going to go into academics, that you have an opportunity to have an immersive experience and create these lifelong connections with people. It's key. And then those of you who are in LMICs working with US teams, I know from my own experience with our own training grant, our Cameroonian trainees tend to be hesitant to bother us. Bother your mentors, bother them, make your presence felt, make them mentor you, especially the American mentors. We will respond to harassment. We will. So you have to harass your mentors, make them mentor you. And you may end up having a lifelong connection, that is going to serve you professionally for the rest of your career. So don't underestimate what you can get accomplished on that front during this time. This is Dr. Shishom. He's we've been partners in Cameroon for 16 years, working on different injury issues. We've been at MPIs on, I think, 6 NIH grants now together. So without him, none of my career would have happened. He's like the key to everything. These two, Manono and Atundi, are also huge. they were very important early on. They're more senior and retiring or retired at this point, but they are lifelong friends. I still email them and ask them about their kids and, hang out when I go to Cameroon and visit them. They all helped me tremendously. And it was because I spent a lot of time hanging out with them and making friends. And now we're truly lifelong friends. That partnership led us to create this program. This is our research program at UCLA called the Program for the Advancement of Surgical Equity. You can see we have a global profile. Dr. Shisham is the lead for the research program in Cameroon. And then we have a US-based research portfolio as well. And we have right now two program managers. We're hiring a third. And we have a number of trainees coming through our pipeline every year. Because a lot of young people from all over the world are very motivated to do health equity related research, which is really inspiring and great to see. This partnership has also allowed us to create a research hub at the University of Buea. We got a large grant called the U54 from the NIH now almost 3 years ago. And it's a data science grant, but we're using it to address issues of surgery, injury, and equity in Africa. So our data, it's called Design Africa, the Data Science Center for the Study of Surgery, Injury, and Equity in Africa. And it's housed at the University of Buea, our local home base in Cameroon, where Dr. Shisham is faculty. And we have missions here, but essentially just improving access to quality surgical care in Cameroon and other similar settings. The design structure is here. We have 3 cores: administrative, data management, and capacity building. And Dr. Shisham is the core, or the hub director. This is Dr. Disak Delong, who's a phenomenal asset. She's an MD, PhD, and is our executive director of our hub. And we have several 5-year research projects and a number of pilot projects. We give grants to African investigators every year who study issues related to injury, surgery, and equity. And what this has really allowed us to do, though, is create more data around injuries. We have 10 hospital trauma registry in Cameroon now. We are getting long-term data. We're following people up to 6 months to see how they do in terms of disability. And all of that is a rich resource for our trainees to do secondary data analyses on. We're creating infrastructure. We have a team of maybe around 30 people now with our research assistants and the various administrative and training roles we have in our hub. And then training. So we also have fellows who work with our group, who are each attached to one of the projects, Cameroonian postdoc fellows that we're trying to help launch their careers. In tandem with this, we also have a program funded through a D43 mechanism, which is also a training grant intended to support scientists from low and middle income countries. And we have this again with Dr. Shisham and his team. And we're essentially, it's called STREAM, the Sustainable Trauma Research Education and Mentoring Program. And our goal is to strengthen the quantitative training of the scientists coming out of the University of Buea and specifically mentor them in trauma-related research projects. So we have 10 trainees through that program as well, 4 MPH, 4 PhD, and 2 postdoctoral fellows. 2 of our postdocs, by the way, Jay, are presenting at CUGH this weekend in LA. So if your people see them, say hi. And then the goal here is to really use those 2 programs together to create an injury center. And this was the goal that Dr. Shisham told me about when I was a resident. He's like, I want to create an injury center, Dr. Manono as well, at the University of Buea. And so we've worked for 16 years to kind of be in the position and now finally try and do this. So we're in the process of trying to build this through these 2 big grants. And hopefully our STREAM graduates will be the future of design and continue to do their work as faculty at the University of Buea. Our goal is to get them to be in the position to be independently funded. Hopefully it's a big goal, but we're going to try to achieve that so that they can continue to do this injury center without the US involved, me involved. And this all came about kind of like a catch as catch can. And I'm going to bring you to my next lesson about that. we had to do one-off kind of opportunistic projects early on because we didn't have any money. We had to be cagey and agile and resourceful and scrappy. And we had all these little things that we published. And now we're in this phase here where we have these little things got together and gave us an opportunity to get these bigger things. And we're trying to work these two big programs together to create a future. We have an integrated, sustainable center that's run by the people we're training. So again, the partners. I think the keys to long-term partnerships are the trust, navigating the roles that each partner has and what each brings to the partnership. I think science is a team sport. No one person does it all. You need people who have big vision. You need people who can count the beans and make sure they're counted correctly. You need people who can go collect the data. Every one of our PIs and investigators on our grants has a different strength. And the goal is to figure out what those are and help them work together. There are always going to be problems, personality conflicts, people who don't pull their weight. That is just part of it. So don't let it derail you. Find the strength in each person and help elevate that person's strength. Sometimes that shifts. When I was a resident, I had a very different skill set than I do now as an attending. And so my role has changed because of that. And same with Dr. Shisham's. Finding the common ground between the external stakeholders, like the funding, the funders, the NIH, the USAID, all the big funders, what are their priorities? And then what are the real priorities on the ground? Sometimes they don't match perfectly. Most of the time they don't, but how do you find the sweet spot where they overlap and then try and push in that direction so you can move things forward? And then always constantly self-evaluate. I think it's really easy in academics to get seduced by the metrics of success we need for promotion. And you do need to stay personally relevant to stay in the game. If I didn't care about publications or funding, I wouldn't have the power to do the things I want to do. That's the game. But you can't let yourself get so obsessed with them that you lose track of the real reason why you're doing these things. So I have to have constant self-evaluation. We have Dr. Shisham and I have talks about, like, where are we really going with this? What are we doing right and wrong so that we can make sure we stay on track? Okay, we talked a little bit about this. You have an opportunity right now to form strong partnerships in other countries. So build your trust and friendship. And it's also more fun, honestly, to do this work when you have friends. I know Mark sends me pictures of all his adventures, and I know he's making friends right now that he will be in touch with forever and continue to work with. Find those like-minded people with big dreams. You're going to meet 10 people who are like, that's impossible, or I just want the money, like, you're not going to be in it for the reasons that we all want to be in it. And then you'll find the person who believes in you, believes in the mission, is willing to play the game with you. And that person is the Shisham of the world, who's an unbelievable person, and hold on to them tightly. Find people with complementary skill sets. I have people on my team who are biostatisticians, epidemiologists. Our executive director, her PhD is in qualitative methods, because I know nothing about that, but we keep finding ourselves in a position where we need to use that, because it's very important when you're exploring new terrain and research to start with qualitative studies so you don't make assumptions that overlook important things. And then mentorship. Like I said, make sure you identify who's going to be a potential mentor. And it may not be, they may not come with a sign on their head that says, I'm your mentor. It may be someone that you don't suspect. But if you find that you resonate with someone, even if they're in a different field than you, nurture that connection, because they may be able to mentor you in other ways. So I would challenge the international-based GloCal fellows to really think about what the U.S. cohort, the faculty, and the trainees in your cohort who may go on to be faculty somewhere at a U.S. institution, what partnerships can be helpful to you in the future here. Be strategic about it. Really think about it. Who do you resonate with? Who do you keep clicking with? Who says something on a Zoom when you're like, yes, send them an email afterwards, talk. Because U.S. people need you and you need them, especially navigating. This is the not everybody. There are big universities, University of Cape Town, Makerere, Aga Khan, who do this quite successfully, don't need a U.S. partner. But the grant application administrative process is extremely burdensome, and many LMIC universities and institutions don't have the administrative human resources to navigate the NIH grant application process or the USAID grant. They are complicated, and we have specialists in our department and our School of Medicine who only do this, many of them, because it's so difficult. So this is an example of where our US institution can help the University of Buia get big funding to do the things they want to do. So nurture those relationships. And like I said before, these are really rare opportunities. So when you're in the middle of it, don't forget to take advantage of it. Okay, so in terms of this, here's a picture at the end of my year of Cameroonian research. We had a meeting. Actually, it was held a couple of years later because we had to analyze the data and everything. But we had a meeting at the end of all the data gathering and analysis at the Ministry of Health, and we presented our data to them. And I felt like embarrassed because there were bona fide like biochemists and HIV researchers there from Cameroon who really did like really complicated research. And my research was like counting how many people got hurt. It was not complicated. And I was embarrassed to give my first study findings. But people were so supportive because everyone, like I said, had been injured or had a family member who'd been injured or killed in a car crash. Trauma globally kills more people than HIV, tuberculosis, and malaria combined. And 90% of those deaths are in low and middle income countries like Cameroon. So it is a huge problem that people are not adequately addressing through science and other policy efforts that take money. So it was like surprisingly well received. That made me so happy. Here I am, my younger version myself. There's Martin Manono, my colleague, Kent Stevens from Hopkins. He's a trauma surgeon at Hopkins, came out for it as well. And here's the head of research at the Ministry of Public Health at the time. Here's a picture. This is not the same time. This is maybe 5 years ago. That's Ariane Christie. She was my mentee at UCSF when I was assistant professor there. And she is now faculty at UCLA. She did the same thing. She went to Cameroon for a year, did some studies, and she came back and presented to the Ministry of Public Health. So we have this like trainee pipeline that's ongoing, and the partnership that's ongoing. And now annually, we try to do a presentation to the Ministry of Public Health to make sure that Dr. Shisham likes to say they're the end user of our research. So we always want to make sure we report back to them. And that was made possible because of the partners I met early on. We have this relationship with the Ministry of Public Health. There's Dr. Atundi. He was initially on my very first, he was the director of the emergency department at Central Hospital of Yaoundé. When I did my first study, he was one of my early mentors. He's been in a couple other pictures. He became the director of disease control in the Ministry of Public Health. So he was a huge link. So again, those early partnerships, hold on to them, because he made all this happen for us to be able to have this partnership with the Ministry of Public Health. That's just another early picture. There's Dr. Atundi right there. This is when we did our first study, when he was the director of the emergency department. And then there's Ariane. She's again looking younger than she does now, even though she still looks really young. They did their data collection. All of these students here are students from the University of Buia who were doing the data collection with her. They had to do their medical theses, and she nested their research questions into her community-based survey on injury, and each of them published a paper with us using their own data from that process. So we hired them as research assistants, developed their own research question, nested it in the same data collection infrastructure, helped them publish. They all passed. They're all doctors now. And one of them is our stream fellow. She's working with us now, and Frida working on brain injury. So we have Ariane made all those friends with her year of doing this work, and we still have relationships with them. Mark is making friends right now that are going to add to our group's ability to have impact. So I keep saying the same thing. Agbor, he's now on our team. Ariane discovered him to do her data collection. He's now one of our program managers for the U54 project. All of these things come from personal connections. All right, the third lesson, these are going to come quicker now. It's okay to be different. I think there's a huge pressure. Academics should be the vanguards of change and innovation because you have unlimited ability to be creative in academics. Strangely, in medicine, we tend to be really traditional, and it's getting better. Surgery is the worst offender. Surgeons are the most traditional, closed-minded. And it was, no one understood what I wanted to do when I was starting to do what I did. And I was too dumb to know that I was taking a big risk. I was too naive to know that what I was doing was very risky. But that was my superpower because it allowed me to go do something that people hadn't seen. They didn't see what I saw. They didn't see it the same way I saw it. Very few did. A few did. Charlie Mock did, others, and I was lucky enough to connect with them, but most people did not. But now it's what defines my career. I'm like, there are very few people when I was doing this who did it. And so now that health equity and global surgery are becoming very popular with the next generation, I'm kind of at the forefront of that because of timing and believing in myself. And I know that seems silly, but if you really see something and you're passionate about it and you know that that's a problem that you can try and help with, lean into that. Don't get dissuaded by the naysayers who aren't creative and don't have your vision. Find the ones who do, and it's okay to be different. It's actually probably going to turn out to be what makes you successful if it works out. I was lucky. There's Jaime Sepulveda was one of the people who believed in me too. He was a wonderful professional mentor. There's Hailey DeBoss. They were this is Rochelle Dicker, another mentor of mine. We were at UCSF. We started the Center for Global Surgical Studies. It's now morphed into the Center, CHESA, the Center for Health Equity in Surgery and Anesthesia, being led by Daruk Ozgadiz, who's also an early pioneer of global surgery work. And now we have PACE, the Program for the Advancement of Surgical Equity at UCLA. And these didn't exist before. And now they do. And they draw people to come do work with us all the time. Every year we have at least one surgery resident, sometimes two, who out of the 7 in our class who does work with us. So it's believe in your ideas. Here's our webpage. Okay, next lesson. Do what you care about. So this is hard to do because especially if you're doing something different, you have to check those boxes. You have to publish your papers. You have to present at meetings. If you get a grant, wonderful. But you have to check those academic boxes to legitimize your bizarre idea. So you got to do that. But you don't want to get taken down a road of just checking boxes and playing the game. You got to do what you care about. So I can weave these last 15, now they're almost 20 years of narrative into a story that makes sense. But like I said, I got hit in the face literally by a car crash, and it didn't occur to me that this was a public health problem at the time. I had to kind of find out the hard way, fumbling around, getting my MPH, meeting Charlie Mock. But the thing that allows it to be a story now that makes sense is because each time I took a step, I had my own internal compass that was guiding me about what I believed in. I had a moment in surgery residency where I could have said, I'm going to go do basic science research with the liver transplant PhD, researcher, because that's the easy way to show that I'm successful. I'll get guaranteed publications. It's a well-trodden path. No one's going to question why I'm doing it. But I didn't love it. I didn't want to do that. And instead I said, I'm going to do this thing I care about. And if I succeed in academics, great. And if I don't want to do that other stuff anyways. I'll be a trauma surgeon and be happy, whatever. So that was, those decisions were critical for me to get where I am today. And it really was about staying true to what you believe in and what you care about. But it may look glossy and easy, but the road along the way can be rough. That's one of Ariane's pictures when they did their community-based survey. Here's another one where I always use this one because it's so striking, but one of our research assistants, one of the villages they had to get to that was sampled through their sampling structure for the community-based survey, a river had formed around it and they couldn't get there. So they had to get off their taxis, take a canoe. And this is the canoe driver carrying our research assistant with her surveys in her hand down to the last mile to do her data collection. So the point here is you may not know where you're going, but if the reasons for your choices are true and consistent, you'll get somewhere you belong. And I know it's hard to do that when you're surrounded by academics and all the ambition, success, all these trappings, but I highly advise that. Okay, funding trajectory. This is the next lesson. Early on, I had to find my own funding as a resident because there was no mechanism like GloCal. I love that this exists now. I'm so happy for our trainees. I created my own NGO called Second Assist. I actually dissolved it about 5 years ago, but it lived for 10 years and it was a way for individuals to give money to this project, to working with Cameroon and a couple other programs that were all working on the problem of injury and surgery. So I created my own nonprofit to do this as a resident, which again seems bonkers to me now, but that's what I did. Then I got my first job and my first recruiting package. So I was able to, I timed it right. I didn't time it right. I got lucky that global surgery was really becoming into vogue. And so I got recruited based on this crazy idea I'd had before. And now it was like something people wanted. So I got a startup package. So negotiating your first startup package, figuring out who's going to support you as a faculty is really important. And then I finally got, after many, many misses, a professional society award. I got the American College of Surgeons Junior Faculty Award. That was my first extramural funding. And then I got two NIH grants after that. And then once you get a few NIH grants, for some reason, they believe in you and like give you more. It's so it's weird. It's like a little thing. But these are all the things I applied to before I got those. So I had, in academics, they say you apply to 10 before you get one. I applied to 28 before I got one because global surgery is so bizarre and there's no National Institute of Trauma and Institute of National Institutes of Health like there's for cancer, other things. Not that it's easy for anyone, but this was an odd thing to do. And I had to kind of get cagey about where I applied. And I applied to 28 before I got my first grant application. And I got two more right after that. Those are the first three grants that I got. So this is a famous thing that people talk about, but success looks so beautiful, but there's all this stuff underneath it that no one talks about. And I'm here today to talk about it with you so that you don't fall for this, Instagram version of what being a successful academic is. There is like a lot of failure. And I would say in global surgery, it's more like this. So persistence, that's the next lesson. Be persistent. You have to be willing to get beat up. 9/10 of academics is failing. So don't let it affect your self-esteem or your your belief in yourself. Get back up. If you really believe in your idea and you know this is a problem, you get back up and do it again. For every success around you, there are 10 to 20 hidden failures. And this is times 20 for global health work. It's harder to get funding, but it's possible. People do it. So just to give you a quick, I'm almost done, but here's a quick alphabet soup. So the NIH is probably, one of my mentors calls it the modern benefactor of scientific research. You know how there used to be rich families in Europe who gave all the Renaissance artists money to have all this beautiful art that we have. The NIH is really the modern benefactor for scientists all over the world. They do give a lot of money to US scientists, but they give a lot of money to scientists all over the world. There are a bunch of different letters. All the grants have funny letters. The GloCal grant has, is it a U? I can't remember. Or is it a D? I can't remember which letter the GloCal grant is.
It's a D43.
Yeah, it's a D43. So it's a D, which is a training grant for international work. But ask your US partners to help you navigate this because GloCal is a great launching pad. It shows that you've gotten some funding already. It's NIH affiliated. There are K awards for LMIC scientists. I'll tell you about them. There's other funders as well, the World Bank, USAID. They're very different animals. So if you want to go for money from one of these places, find someone who's been successful who can mentor you because each one of these has their own like way of doing stuff and it's really confusing. And I had to figure it out kind of by myself initially. And I can tell you, once you get someone who knows how to do it, it's a lot more helpful. And then there's like, kind of other options out there for LMIC investigators through Europe, Welcome, There's a Swedish federal funding agency. There are African funds available, but you have to take time to look through. And again, mentorship is really helpful in finding these opportunities. You guys know the GloCal Award. It's a great one, but there's also this, the Emerging Global Leader Award. So those of you who are postdoctoral and this is your GloCal, I would think about talking to your mentors about this, to think about talking to your mentors about your next steps. Where are you going to go after this year in terms of your funding so that you can continue to do work? So this is the link, and I can send my slides to you all for this funding opportunity. For US-based ones, there's this kind of similar award called a KO1, and Dr. Christie, my former trainee, now she's my partner, is on that right now. It's also a mentored global health training grant. I think it's called the International Health Scientist Development Award, but it's also a K award, 3 to 5 years, and it gives you protected salary and a little bit of money to have a mentored research experience so that you can get yourself ready to apply for independent funding. So both of these are mentor research grants. So your GloCal mentors probably know about them and probably could help you figure out how to apply. Finally, I don't know if this is final, we're close though. Find a way to contribute. I think this is especially true for the US trainees. I went to Cameroon when I had done 2 years of surgery residency. I was not going to help Dr. Shishom do anything surgical. I could barely do anything. I was like better at writing notes than doing surgery. But I got good biostats training from Marie Diener West at Johns Hopkins. And when Dr. Shisham came to me, it's like, I have all this data, but I want to write it up. I was like, I can do that. I can analyze those data and help you write it up in a scientific way. So you have skills that you have learned throughout your education that are probably different than the ones that your partners have, and vice versa. So figure out how you can contribute meaningfully instead of forcing your idea of what you think should happen onto your partner. So that's another one I learned, and I give that one to my trainees as well. And then the last one, check the boxes, but don't lose sight of the real goal. To be academically relevant, you have to
I think Katrine's internet just dropped, but I'm hopeful that she comes back. What an inspiring journey that she shared. So let's wait a few minutes. I think we still have a few more minutes, so hopefully she can get back on. There she is.
back.
Hi, Katrine.
Hi, can you see me? I don't know what happened.
Yeah, you were kind
I
of
don't have very much
freezing in
more to
and out, but
say.
we were able to hear you throughout your talk. So I think the last one was your lesson number 6. Um, but
Oh,
can you
well,
hear?
now I'm at 8. I'll
Okay.
just finish. 7 wasn't that important.
Okay. Yeah, I mean
So,
we
can
still
you
have a
hear me
few more
now?
minutes, so you can just share your final thoughts, and then we can open up for a few
Sure.
minutes for questions. Oh, she was here, and the joys of modern technology.
Maybe we should just go to questions.
Sure,
It
sure.
seems to not be working. Can you?
Yeah, yeah. Well,
Are
yeah, just when you dropped off. Oh, there you are. Okay. Yeah, I was sharing with the fellows how inspiring your story was, and it's such a positive, like hopeful, like perspective in terms of how we do global work, and a lot of the lessons that you shared really resonated with me, and I'm sure many of us. So let's we still have like 6 minutes, so if you want to ask questions, please feel free to unmute or put it in the chat. Hey, Dr. Gama. Okay, Katrin, can you see the chat, or I can it was basically,
Yeah,
yeah,
thank
brilliant.
you.
And 8th Avenue.
Okay, let's see.
Thanks so much. I'm glad you
I
enjoyed
have
it.
a
If you have
question.
questions after this, email me. Yeah, please.
Yeah, I'm just thinking from the perspective of LMIC institutions which are new or just still developing capacity. Do you have any experience in helping develop that sort of research and grants management capacity on a structural or institutional level, like the G11, I think,
Yes,
or that sort of thing that actually builds the
that
institution
is,
up
I
to
was
be
just
able
gonna say the
to
G11.
to host and well, that's okay, great.
Yeah, Gamma, I think Katrine was saying that, in terms of supporting LMIC institutions with their like research capacity, I think you're right. There's a mechanism called G11 that LMIC institutions can apply for. And I think I believe it's like 2 or 3 year funding. And that provides an infrastructure to be able to propose like a training grant led by an LMIC institution. So, I think the G11 mechanism is really great. And then there's also, so like the GloCal is like a D43 mechanism, but I think there's like a preparatory I forget what the number is, like D73 or something that is like a preparation for D43 mechanism. So there's like G11 infrastructure support, and then D73, I think, and then there's D43. So I think, as Katrine mentioned, there are opportunities from NIH that you can leverage to be able to, build capacity for LMIC.
Can you guys hear me again?
Yes.
Okay, sorry about that. I was going to say too, we've learned a little bit about this too through our U54 experience because we're trying to help University of Buea develop that. And one of the big hurdles is I think people who haven't had NIH funding don't realize what a like beast it is to manage. And so it may be that your leaders and administrators may not totally understand how difficult it is. So they don't know how to provide the support to even create opportunities. So like the G11 is a catch-22 because you have to be able to apply for it. It's a great mechanism.
Yeah.
The NIH actually has periodically training webinars to help people learn how to apply for certain grants. And I think whatever you can do to get on listservs, like the Fogarty has a listserv, it's a center at the NIH that specializes in international health. And then the NIHD, National Institutes of Minority Health and Health Disparities, I get on their listserv. So every week I get an email with all the funding opportunities. And occasionally they'll put in there, oh, we're having a webinar on these days that is virtual and it's, a 5-hour training session. You can have the person that would be your grants administrator, the first one, do that training session, and then they start learning, oh, okay, this is complicated. Let me talk to our dean about that because this is going to take more than we thought. But I can I'm just going to the phone now because I've given up. But I can tell you that the payoff is huge because once you're able to get NIH money, you get for foreign entities, it's 8% indirect. It's a lot less. But oh, now I'm back on both. Geez, I feel like I'm in Cameroon. The 8%. So if you get a $1 million grant, you get $80,000 that goes to your institution for indirect costs, and that goes to pay what it costs to have the grants management team, for instance. So all of this is complicated, but the webinars are a great way to start because then the people in your own institution start to understand what's at stake and how complicated it is and what's needed. Thank you, Jay. Yeah.
So there's a link where you can click and then you can subscribe to NIH funding, listserv and newsletters. So really great resource that Katrine mentioned.
Fogarty is also great because they will do a really thorough search of other institutes. So the NIH is made up of different institutes that are mostly disease-based, like National Cancer Institute, Heart, Lung, and Blood. They do a lot of like coagulopathy and cardiac research, but it's usually disease-based, but they each have kind of like secret global health portfolios that are very hard to navigate from the outside. But the Fogarty listserv will go through every week and find global health opportunities through other institutes as well and put the links in their email. So that listserv is like super valuable to be on. It's really well resourced. And they look at like the Gates Foundation has something. They'll look outside the NIH as well and put it in there.
All right, so we are right at time. So Katrine, thank you so much again for sharing your experience with all of us and really appreciate you.
My pleasure. I'm sorry that my internet was like so crazy.
Yeah, it's expected.
Yeah.
It always
Well-
happens to me when I wanted to make a comment and then my internet drops. Nobody understands what I said, so.
Mark's in Cameroon and his internet's been perfect the entire time.
All right, thank you all. So I know that I think, Julie, we have our next one in April that we have scheduled, right?
Yes.
So, all right, so we will see each other again in a month. And then I think there's also works in progress that's going to be coming. So,
Exactly.
all right,
Thank you.
thank you
Thank you
all
for
and have a
doing so
great
much.
rest of the day.
Thanks, everyone.
Thank you very
Right.
much.
Thank you for having me.
Bye.
Thanks. Bye.
Bye.